All right, welcome back, everybody, to the Ultrasound Grand Rounds this week. Pretty excited. We've had some pretty rock solid weeks the last few weeks, just with the topics that we've been talking about. Just got posted up the video that we did with Ashish last week about advanced Doppler and pericardial tamponade. So if you haven't had a chance to watch that, it's now live on YouTube. Well, not live, but it's now posted on YouTube, and so you can go back and look at that and watch that. We talked about some really good stuff about ventricular interdependence. But today we're going to carry on that heart theme. We're going to carry on the recitative theme. We're going to bring in another one of our colleagues here in the hospital. And I'm really excited to invite to this lecture series, Dr. Robert Owen. He's one of our cardiac anesthesiologists. He and I had a chance to meet a couple months ago at the Critical Care Ultrasound Fellows Conference. And he gave it a spectacular lecture about the use of transesophageal echo in critical care or in the resuscitative environment. And so I thought, what better opportunity to have him on our forum, have him explain a little bit more about his use of TEE in the OR in ways that we can then translate some of that use of ultrasound, use of echo down into our resuscitative environments, whether it be in the ED or the critical care environment. So without further delay, I'm going to turn things over to Dr. Owen and go ahead and take it away. I'm pretty excited to have you here and hear what you have to say for us today.
Excellent. Thank you very much, Dr. Tabbitt. I'm going to go ahead and share my... Okay, so as Dr. Tabbitt said, I'm Robert Owen. I'm one of our cardiac anesthesiologists here at Metro. So I'll be talking about transesophageal echocardiography in the critical care as well as the emergency medicine setting. Here are our objectives for today. We'll talk about the indications for using TEE, including some of the evidence supporting its use, particularly in a rescue setting. We'll talk about the contraindications, relative and absolute, for TEE. We'll look at some of those potential complications that you do have to be wary of before putting a probe in someone. And then we'll go through the 20 basic TEE views with a specific focus on the high-yield views that can be used in resuscitative and critical care TEE. And then I'm going to show a few clips of some pathologies with some normal clips also kind of side by side as long as technology doesn't fail us today. Unfortunately, I have no disclosures to make, but I'm always willing to change this slide for the right price. So let's talk about why throw a TEE in someone. For me, in the perioperative setting, there are a certain set of indications. Perioperative TEE and intraoperative TEE is Class A recommended for any valvular open heart surgery, and it's vastly becoming a higher and higher recommendation. I think right now it's a 2A recommendation to do perioperative TEE, even in coronary artery bypass surgery. So that's where I kind of work, but the use of TEE goes well beyond the OR now. So in critical care patients, and I apologize, these societal recommendations, so this is ASA, the American Society of Anesthesiology, as well as SCA, Society for Cardiac Anesthesiologists. And these are kind of the guidelines, again, for perioperative. But what they mention about for critical care patients, it should be used when diagnostic information that is expected to alter management cannot be obtained by transthoracic echo or other modalities in a timely manner. Now, I'm aware I'm talking to an audience that is very well practiced in transthoracic echo as well as FAST. However, we all know there are situations like when there is a knife in someone's chest, when there's subcutaneous emphysema in a trauma patient, where transthoracic echo is not really going to be a useful modality. Plus, there are certain benefits of TEE specifically. So one of the particularly useful things are for far field structures, such as the aorta and the left atrial appendage. A lot of folks will find that transthoracic echo isn't as useful in those, as well as for assessing prosthetic heart valves, vegetations, paravalvular abscesses. We all know that ruling out infective endocarditis, the gold standard, is going to be a transesophageal echo. And then, like I said, different conditions, dressings, wounds. Some of our critical care fellows here will obviously get some of our post-op cardiac surgical patients who have sternal dressings and a Provena on. Makes it very difficult to do transthoracic echo in that setting. And we do unfortunately live with a very large patient population where your windows sometimes just aren't there. So if the findings are going to alter management and TTE is going to be either non-diagnostic or impossible because of the patient condition, TEE is a very reasonable thing to go to. And this is 2013. ASE is the American Society of Echocardiography, and then SCA, Society for Cardiac Anesthesiology. The other thing that TEE can be useful for is going to be procedural guidance. I think the most germane for emergency medicine as well as critical care medicine is going to be guidance for mechanical circulatory support initiation, like a balloon pump, Impella, and ECMO. However, I found it also useful. I actually use it while placing central lines. If I'm already doing a TEE, you can make sure that your wire is in the right place. It can be useful if you're placing transvenous pacing wires to help position things for that. So it can also be used for procedural guidance. It can be used in procedural guidance when performing pericardiocentesis. One of the things we often use it for is when we're doing lead extractions, we monitor via TEE for the development of any pericardial effusions. So the idea of resuscitative TEE is the use of TEE in the ER and in the ICU setting to provide diagnostic and hemodynamic information to support decision-making in the resuscitation of critically ill patients. And again, this is when a transthoracic echo or other modalities would be non-diagnostic or impossible. And something that actually had been new to me until I started preparing this presentation is the idea of using TEE as an adjunct during ACLS to monitor the adequacy of compressions by looking at aortic valve opening. So here's a little clip I found online. So obviously we see this heart is in trouble. They start doing CPR. And obviously it's, all going quickly, good, timely compressions, but we can see, and as we'll get to, this is the mid-esophageal long axis view. We can actually see the aortic valve opening with each compression. So it can be used to help make sure that you are providing perfusion with your compressions. So some of the evidence, why do we do this? Is it actually helpful? Large meta-analysis of critical care TEE studies that included 108 different studies over 6,500 patients, and looking at was TEE useful in changing the diagnosis and management. So it was found to be useful in changing the diagnosis in half to 3/4 of patients. So you can really narrow down your diagnosis quite a bit by using TEE. And then it was reported to change management anywhere from 1/3 to 4/5 of patients. Obviously, this is a very wide range of patients, but you can see that even if it's changing your management in 1/3 of your patients, that is a ton of patients. The number of people that we have in critical care settings who go into undifferentiated shock, this can really be helpful for you when you don't have other modalities to provide you your management and diagnostic information. And then when using cardiac arrest, so in addition to monitoring the adequacy of compressions, TEE can be useful just like TTE during cardiac arrest in identifying the cause of arrest in up to 35% of patients. And one of the benefits that TEE offers is that as opposed to trying to get your subcostal view while doing pulse checks during ACLS, the TEE only has to be inserted once and it stays there. So you don't have to interrupt compressions for as long to try and get your view and see what's going on with the heart. So it's a great modality, but there are definitely contraindications. One thing that I do want to point out is that there's a little bit of discrepancy depending on who you're asking what the absolute and relative contraindications are. So again, ASA, SCA, they hedge a little bit on what the contraindications are for TEE. And they ultimately say if expected benefit outweighs the potential risk, go ahead. Other societies and authors are a little bit less ambiguous. So Dr. Ron Kahn, writing for a chapter in Kaplan's Cardiac Anesthesiology, lists that the absolute contraindications are going to be diverticula, tumors, esophageal strictures, recent suture lines, and known esophageal interruption. Most of the things that you're going to find is that the ones that are most often shared between the different societies and the different authors are going to be things like esophageal strictures, tumors, obviously any known hollow viscous injury is going to be something, especially esophageal and even gastric, are going to be your absolute contraindications usually. Some of the relative contraindications: hiatal hernias, esophagitis, coagulopathy, esophageal varices, unexplained GI bleeding. At the same time, during liver transplants, for instance, it's pretty much our standard to use transesophageal echo, unless a patient has had extraordinarily recent banding of their varices and is extraordinarily coagulopathic. So another author, Hauser, obviously writing from somewhere in Europe due to the spelling of esophagus. Absolute contraindications. Sorry? Was there a question? Absolute contraindications, strictures, fistulas, known trauma. This is something that I want you to pay attention to, is that obviously in our polytrauma patients, sometimes there can be question of esophageal trauma. So it is definitely something that you want to think twice about before dropping a probe in a patient if you do suspect esophageal perforation already. Esophagectomy, obviously, and then perforated viscus. Diverticulum helix is a relative contraindication, again, compared to Dr. Kahn, who lists it as an absolute. Tumors, again, Hauser lists it as a relative contraindication, whereas Dr. Kahn will call it an absolute. Mallory-Weiss tears, thoracic radiotherapy, colonic interpositions. One of the things that I don't think gets mentioned enough is actually atlantoaxial joint disease. You do have to do a little bit of cervical spine manipulation in order to place the probe. So another thing particularly germane to our emergency medicine colleagues is that if you haven't cleared the C-spine, I would not consider it an absolute contraindication, and I don't think most people would, but you definitely have to wonder, okay, are the benefits going to outweigh the risks in this particular situation? It can also become a little bit difficult to place the probe itself in those situations. Another one that I don't think gets talked about enough, thoracic aortic aneurysm. Just the presence of the probe in the esophagus can place pressure on an aneurysm that if it's already getting ready to burst, you don't want to add any more pressure to that structure. Ellison, again, we see some things that were called relative contraindications by others are going to be called absolute contraindications. For instance, Ellison calls a Mallory-Weiss tear an absolute contraindication. Diverticula, we've seen, has fallen on either an absolute or relative. Poor airway control, another one that doesn't get talked about enough. If you don't have a secured airway and you anticipate that you might need one, you should probably secure the airway before you place a TEE. Uncooperative, unsedated patients generally are critically ill patients are going to be sedated or will require some at some point. And then we see the long list of relative contraindications. Trying to see if there's anything really new here. Post-gastrostomy, fundoplication, esophageal cancers, vascular rings for a similar reason to the thoracic aortic aneurysm, history of dysphagia, Barrett's esophagus, peptic ulcer disease. I would also add in here, I don't think anyone has mentioned it, but depending on how you are using your TEE, if you do intend on going into the stomach, you do want to be quite wary of any patient who has had bariatric surgery in the past that you may have difficulties entering into the stomach, and you absolutely don't want to push it if you are having any resistance whatsoever. And most people, myself included, will avoid doing stomach views in a patient who have had bariatric surgery in the past. So why is it that we go through all of these contraindications? Obviously, the biggest thing that you worry about is going to be an esophageal perforation. It's extraordinarily rare. Again, fairly wide range of reported incidents. I would hope it's closer to this 0.2 rather than 1.4%, but it can be absolutely, this is the overall complication rate. Yeah, the esophageal perforation, extraordinarily rare. But it can be extraordinarily devastating, often up to a 50% mortality. Patients unfortunately develop severe mediastinitis and do not do very well. The other complications that can happen with TEE, most of them are going to be kind of lip, tongue, or pharyngeal lacerations and dental injuries. But of course, you can cause injuries to the esophagus that go beyond, just perforation. You can have Mallory-Weiss tears, dysphagia. Sometimes you can absolutely injure the airway, vocal cords. I've seen people injure the posterior arytenoids while trying to place a TEE probe. So most of these complications are all going to be with the placement and insertion of the TEE probe. One thing that I think also does not get talked about enough is that the pictures that you get with TEE are absolutely stunning and beautiful, and it is easy to lose focus on everything else that is happening to the patient while you're looking at the images. So something I really hammer home to my residents is the TEE is another one of our monitors, just like our ART line, just like our central line, just like our EKG and our pulse ox. It's something to contribute to your overall understanding of the patient. And if you get fixated on it and ignore everything else, it can become extraordinarily dangerous. I've seen people inadvertently detach the breathing circuit from the anesthesia machine, from the endotracheal tube, and now you've got an apneic patient. And if you're just looking at these beautiful images but not paying attention to the patient as a whole, you can cause quite a bit of harm to the patient. So this is one that I do want to hammer home, especially to people who are used to looking at transthoracic images, which can be great, but I think most of us who have seen both transthoracic and transesophageal images would agree that the TEE images are just absolutely stunning. And part of that are the unique tools that exist in TEE that don't necessarily exist in TTE. So some of those tools include omniplane, which is changing the angle that the ultrasound beam is projected from 0 up to 180 degrees. And this allows you to see different structures without having to move the probe at all. X-plane, which gives you a simultaneous imaging of two orthogonal planes. For instance, if you're at 0 degrees, it would give you in the same screen the image at 90 degrees. And then, of course, we can do 3D imaging and reconstruction of different cardiac structures, particularly valves. I like to say that the Lords invented the mitral valve for transesophageal echocardiography. But there's always a balance between spatial and temporal resolution. You can only get a good 3D image from a great 2D image. But those are some of the unique tools that make TEE a very useful tool. So when I talk about movements with the TEE. There's advancing withdrawing. That seems pretty self-explanatory. Rotating, I'll often call it, turning clockwise, counterclockwise. That's moving the probe itself with your hands and your wrist. Antiflexion and retroflexion. So there's two wheels on the TEE probe. The large wheel will provide antiflexion, which obviously flexes the probe tip in an antegrade manner, and then retroflexion in a retrograde manner. There's also a small wheel that allows a small degree of flexing to the left and right. This is mostly useful for obtaining the deep transgastric view. I would recommend never use that small wheel, the left to right flexion, when you are still in the esophagus. Only do so when you're in the stomach because you have enough room to do that. When you're in the esophagus, I think you risk causing too much esophageal trauma. So I never use that small wheel when you're in the esophagus still. And then omniplaning, like I said, you change the angle that the ultrasound beams are actually sent out from those piezoelectric crystals. So there are 20 basic views in a basic TEE exam. I'm going to briefly go through them with a particular focus on these 4 views that I've starred. These 4 views have kind of been advocated as the highest yield views when performing resuscitative TEE. I think that there are a few other views that also are extraordinarily high yield that I would recommend adding to those 4, but I'll go through those as we go along. Just a few abbreviations: upper esophageal, metaesophageal, transgastric, short axis, and long axis. All right. So you place a probe. Generally, when you do so, you're going to get into the mid-esophagus, and this is going to be the first image that you see. As we go through these views, these are all going to be still images, so don't think that I'm having technical difficulties yet. We'll get to those. This is obtained at 0 degrees. Whenever I mention degree, that's going to be the degree of the omniplane. That can always be viewed right up here. One other thing that I think should be noted right up here is the temperature. The TEE probe heats up. So one other complication of TEE that can cause esophageal injury is you can cause thermal esophageal injury. Therefore, I would recommend, whenever not actively obtaining images, to freeze the probe so that it does not generate as much heat. Anyways, in this mid-esophageal 4-chamber view, you get great imaging of global cardiac function. You see all 4 chambers. You see the tricuspid valve over here, the mitral valve over here, and you can see growth pathologies. Obviously, we can place color Doppler, pulse wave Doppler, continuous Doppler through any of these valves. With the color Doppler, you can see torrential MR, for instance, from a ruptured papillary muscle due to myocardial infarction, for instance. So this is a very helpful view, and I would also kind of consider it your home base, from which it's easy to navigate to the other views. If you change your omniplane from 0 degrees to 60 degrees while focusing on the mitral valve, you get this mid-esophageal mitral commissural view. This is particularly useful in delineating the different scallops of the mitral valve. Not something terribly useful in the critical care or emergency care setting, but you can sometimes get a good view of the left atrial appendage if you have a patient who you need to do a cardioversion, but you want to rule out a left atrial appendage thrombus. You can sometimes get a good view of it here in this 60-degree view. Mid-esophageal 2-chamber view. So going from 60 to 90 degrees, you get the left atrium and the left ventricle. Again, you can get a good view of this left atrial appendage. And something that's useful here, you can see the anterior and inferior wall functions. When trying to orient yourself in TEE, it's important to remember what are my anterior structures. So the left atrial appendage, for instance, is an anterior structure. So that can help you orient yourself. Okay, now I know this is the anterior wall. The coronary sinus, which is right here, is an inferior or posterior structure. Cardiologists often will call things posterior. Anesthesiologists will often call it inferior. You'll forgive me if I say inferior. But because of that, okay, now I know this is the inferior wall. So you can look for regional wall motion abnormalities here. You can also see mitral valve function. The mid-esophageal long axis view. So this is usually obtained at about 120 degrees. The point is you want to get the apex of the left ventricle. You have your left atrium, your mitral valve. You want to see the LVOT here, the aortic valve, and you want to see the aortic root. Here are your sinuses of Valsalva, your ST junction, and then your proximal ascending aorta. You can also see the right ventricle in this view. This is a very high yield view. This is what I set as my home base when disconnecting from cardiopulmonary bypass, because I can see a lot of different pathologies here. Mitral valve pathologies, aortic valve pathologies, the aortic root, you can look for dissections. Unfortunately, I've seen a number of iatrogenic dissections when trying to disconnect from cardiopulmonary bypass. Anteroseptal and inferolateral wall motion. One of the things that I liked this picture of is that you can see, obviously, aortic valve is open, right? So we're in systole, but this doesn't look like it's going to be very helpful for your cardiac output. So this is someone who's experiencing SAMing, so systolic anterior motion of the mitral valve. So you can see this and know, okay, I want to give volume, I want to bring down the heart rate, and I want to increase my afterload. So volume and phenylephrine would be a great choice for this patient if you see this. Focusing in on that aortic valve from usually about the same angle at about 120 degrees, you get the mid-esophageal aortic valve in long axis. Again, you can see that root of the aorta. And that's where I go to just measure different measurements for these structures to help with hemodynamic calculations. The orthogonal view to that is going to be your mid-esophageal aortic valve short axis, usually obtained from 30 to 40 degrees. One of the things that's often tested on anesthesiology in training exams and board exams is they'll give you this image and ask you to identify the coronary cusps. I don't know if that is tested on other specialties, but it is something that can be useful. Moving on, 60 to 70 degrees, focusing in on the RV, you get the RV inflow outflow view. I would consider this to be another high yield view. I've unfortunately diagnosed some pulmonary emboli, clot in transit, RV dysfunction from a PE or some other cause in this view. You do see the aortic valve, you're just not focused on it. But the big thing is you can see this RV free wall. You see the pulmonic valve, and you can see the tricuspid as well. So I would consider this to be a fairly high yield view because I like to say the Lord's favorite ventricle is the right ventricle, and if you have a problem with it, you need to know about it. Moving on, another one that is considered high yield, particularly in resuscitative TEE, is this mid-esophageal bicaval view. So again, as long as you're in the esophagus, the structure closest to your probe is going to be the left atrium. So here's your right atrium. You can look at the interatrial septum for any defects. This is where I look for PFOs or ASDs. When you're at this about 90-degree view, I usually just think of, all right, the head is going to be kind of to the right of my screen and the feet to the left. So that kind of helps you orient. This is going to be your SVC and your IVC. You can look a little bit for volume responsiveness. And I find this to be the most helpful view when doing procedures. So this is where I look for my residence wire when they're placing a central line. Now, obviously, when someone has, ICDs and pacemakers, there can be a lot of hardware going through here. So you have to be able to identify what is what. But this is a great view for procedural guidance. If you change it a little bit, sometimes you can see the right atrial appendage here. There's also modified bicable, which I don't think is actually one of the standards. If it is, we'll get to it. All right. So moving on, we have the mid-esophageal ascending aorta in short axis. So you actually do have to pull up a little bit, but it is still considered mid-esophageal. Usually obtained 0 to 10 degrees. You see the ascending aorta, obviously in short axis. Here you see the IVC. What I find this useful for is you see the main pulmonary artery, and it splits off into this right pulmonary artery. The left pulmonary artery is often obscured by the left main bronchus. Obviously, we all know air does not transmit ultrasound waves very well, so you're going to get dropout there. I use this particularly in confirming the position of a PA catheter. Often you want to get it right into this right pulmonary artery. Turning 90 degrees from that short axis view, you get mid-esophageal ascending aorta in long axis. Again, you're going to see ascending aorta. You'll see the right pulmonary artery now in short axis. These two views can be helpful if you're looking at different aortic pathologies, such as ascending aneurysms and also dissections. The upper esophageal aortic arch in long axis, obtained at 0 degrees, pretty easily named. You're looking at the aortic arch. Very occasionally, you can see the innominate vein in this view. Here we have the upper esophageal aortic arch in short axis. Anytime you have something in long axis, if you want to get to short axis, just go 90 degrees and vice versa. Right. Here you can see the pulmonic valve, a little bit of the RVOT. This is going to be your main pulmonary artery. Here's your aortic arch in short axis. Here you can kind of see the innominate vein. So transgastric views. Now we're going into the stomach. First, we've got the transgastric basal short axis. So obviously we're towards the base of the heart. You're going to get this classic fish mouth view. That's your mitral valve and mitral apparatus. You can look for circumferential wall motion abnormalities in the basal portion of the LV. And again, you can delineate different cusps of the mitral valve. Less useful for you guys. But what is very useful, extraordinarily useful, is this transgastric mid-papillary short axis view. So this gives you a circumferential view of the left ventricle. You also see the right ventricle, which means if your right ventricle is blown and you have abnormal septal movement, again, from potentially a PE, you can see that in this view. If you have a massive anterior MI, you can see that with anterior wall hypokinesis. Now, I just pointed here for the anterior wall because something I want you guys to remember is that this looks an awful lot like your TTE parasternal short axis view, right? But remember where the probe is for TTE versus TEE. Structure closest to my TEE probe is going to be the inferior or posterior wall of the LV. So this is going to be your RCA distribution here. This is going to be your LAD distribution here. This is going to be your anterior wall, septum, lateral wall, anterolateral papillary muscle, posterior medial. So this is heavily tested in anesthesia. I know. I have a feeling that this is probably heavily tested in critical care. You have to know your coronary distributions for this. And again, looking at the LV and RV relative sizes. Turning 90 degrees, you can get your transgastric two-chamber, LV, LA, mitral valve. You can see the entirety of the inferior and anterior walls. So something that I'll often do is I will get this beautiful transgastric mid-pap view, and I will use that X-plane function that I told you about so that I can also get my two-chamber view. This allows me to see in the mid-pap view this circumferential wall motion abnormalities. But let's say that I have a basal wall motion abnormality, just basal inferior, or I have apical wall motion abnormalities. Let's say a patient is having Takotsubo. This allows me to see the entirety of that inferior and anterior wall. By using that X-plane function, I can look at those two views together, and I can often identify any place within the coronary vasculature that there would be a lesion. Moving on, at about 120 degrees, you get this transgastric long axis view. You see your LVOT. You can see ascending aorta here, your left ventricle. Our transgastric RV inflow outflow. I think this is a lovely view because it demonstrates the odd shape of the right ventricle. It's not just a cone. It really wraps around the left ventricle. But I wouldn't necessarily consider it a very high yield view for resuscitative TEE. This is actually one of my favorite views. This is the deep transgastric long axis view. You advance into the stomach pretty much all the way. You do a good anteflexion. You retract until you're up against the stomach wall and get your view. And this is where I use that small valve to do usually a right tilt a little bit to get this view. Very useful for aligning pulse wave or continuous wave Doppler to get transaortic gradients, but you can see left atrium, left ventricle, your mitral valve, and your aortic valve as well. This is very useful in someone who has a prosthetic valve because it allows you to get a view of these structures without the intense acoustic dropout that you will get with a prosthetic valve. And then the descending aorta short axis, you're in the stomach, you turn, find the aorta, it's at 0 degrees, and you can trace the descending aorta from the stomach all the way up into the chest until you get to the arch. Sometimes you can see mesenteric vessels. You can also often see pleural fluid when you're looking in the thorax. So this is actually a view that I think could be high yield for you while performing a resuscitative TEE. Generally, what I do is I start in the stomach, I get this view, and I trace the aorta all the way up. If you did an orthogonal view at 90 degrees, you would see the descending aorta in long axis. So I talked about those 4 views that are considered really high yield for resuscitative TEE. And if you want more information on resuscitative TEE, I found this really lovely site, resuscitativetee.com, very adequately named. That gives you a lot of information. There are different lectures on there, different protocols that different institutions have, an abundance of literature talking about the use of resuscitative TEE. And this is what they kind of recommend as those 4 high yield views and what they can be used for. So I think we went through all of those. What I would add is I think that viewing the aorta, so the descending and ascending aortas in short axis, I think are extraordinarily important. And the other one I think that I've certainly made life-changing diagnoses on is going to be that metaesophageal RV inflow-outflow view. So now let's get to some pathologies and how TEE can be useful. All right. So this is a clip from New England Journal of Medicine. This is obviously a metaesophageal 4-chamber view, and we can see that, oh, that was quick. We can see that the size of that RV is massive. It should not be the same size of the LV, and it's not moving well. So we've got a problem here. This is in the same patient, putting color flow Doppler through the tricuspid valve. We see torrential tricuspid regurgitation, which is often a sign of RV dysfunction and RV enlargement. Here we get the transgastric mid-pap, well, it's actually more basal short axis view because you can see the mitral apparatus there. Again, this RV is huge, and you see that septal flattening during systole. You're not supposed to see that. So if anyone would like to shout out what they think would be the most likely diagnosis. Anyone? Bueller?
PE.
PE. That would absolutely be my number 1 diagnosis as well. You get that acute dilation of the RV and RV dysfunction. So now after they've treated the PE and actually put this patient on mechanical circulatory support, you see improvement of the RV as well as the tricuspid valve. All right, so moving on. This is actually a clip that I got myself in our PACU when I was using Rescue TEE to try and give me a diagnosis on a patient that was not doing well. So it's kind of a RV inflow, outflow, metaesophageal. And if you guys can see that, you never want to see that in a patient. This was a morbidly obese patient, over 600 pounds, who presented for bariatric surgery and was decompensating in the PACU. Anyone want to tell me what they see in this that looks ugly? Anyone? So this is actually thrombus moving around in the RV. This patient had been on anticoagulation for DVT prophylaxis merely due to his immobility. He was not bridged with heparin. He merely stopped his anticoagulation, probably walked into the OR with a DVT that day, threw a PE. Unfortunately, he succumbed about a week later. All right, moving on. Now, obviously, the title of this gives it away. But again, this is a metaesophageal 4-chamber view. We're at 0 degrees. And you can see this massive pericardial effusion, complete collapse of the right atrium and right ventricle. This patient is in tamponade. You need to put a needle into that pericardium immediately. This was kind of a funny picture that apparently has been going around on the tickety-tockety. So, oh my, apologize for that. So you can see they're doing CPR right now, right? And when they stop CPR, the patient is clearly in ventricular fibrillation. You see no organized movement of that heart. And again, we're in that metaesophageal 4-chamber view. They defibrillate the patient, and we return to sinus rhythm. RV looks ugly, though. LV doesn't look much better. So I thought that was a kind of a fun clip. All right, we have a few clips here that have a normal and an abnormal next to them. So this view on the right is probably your more metaesophageal long axis view. This would be metaesophageal aortic valve in long axis. But you can see the difference here. You have this dissection flap in this abnormal view. This patient needs to come to the OR immediately, and you need to start them probably on an esmolol drip to decrease their shear forces. But this is a surgical emergency for a type A dissection. And this can obviously happen due to uncontrolled hypertensive disease, but it can also be the result of traumatic dissections. Here we have that descending aorta. Or actually, no, this is a metaesophageal ascending aorta in short axis, because you can see the IVC here, and this is the PA, the main PA and right pulmonary artery. That's a normal view. And then here, again, we see a dissection flap. Very bad. All right. Again, like I said, I think the descending aorta short axis could be a very high yield view in resuscitative TEE. One of the things that I always look for before I take a patient to the ICU after cardiac surgery is there blood in the chest? So here we see the aorta in short axis. This here is lung, right? You guys are probably familiar with what lung looks like on ultrasound. It kind of looks very much like liver, but this is fluid in the left chest. So you can have a trauma patient with a massive pleural effusion that maybe you need to throw a chest tube in. Right. And then going to that other high yield view, the transgastric mid-papillary short axis view. We see normal here on the left, and we see very abnormal here on the right. Could someone remind me which wall is this that is hypokinetic or essentially akinetic?
That anterior septal?
So that's actually going to be the inferior wall. Remember, this is the opposite of your transthoracic parasternal short. So I'm actually glad you said that, just because you have to remember that this is the mirror image of that. So anterior is going to be towards the bottom of your screen, and inferior is going to be towards the top. So that's going to be a really bad looking inferior wall. You got to suspect a RCA problem. All right, so in summary, TEE is an absolutely wonderful diagnostic tool. It is reasonable in both the critical care and emergency settings for an unstable patient for whom transthoracic echo is impossible or unlikely to yield the diagnostic results that you need in order to treat this patient appropriately. It can also be used for procedural guidance, as I said, particularly in the placement of mechanical circulatory support, transvenous pacing lines, as well as central lines. Okay. While not universal, there's a list of absolute and relative contraindications. I would say most people would say these absolute contraindications are going to be strictures, masses, diverticula, perforations, Mallory-Weiss tears, esophagectomy, and TE fistulas. But do remember that list of relative contraindications and ask yourself before dropping that probe in, are my expected benefits outweighing the risks of dropping this probe in someone who has, a thoracic aortic aneurysm, someone who has a C-spine that's not clear, someone who has a history of varices. But it is, on the whole, very safe, but the complications, particularly perforation, have the ability to be devastating and fatal. More summaries for those of you who are still in training. Their TEE views, I think, are being increasingly tested. Certainly in anesthesiology, they are. I think they are in emergency medicine as well as in critical care. I'd say the highest views in terms of testing are going to be that transgastric short axis mid-pap. Again, remember, it mirrors the transthoracic parasternal short axis, and you have to know your coronary distributions. That mid-esophageal four-chamber for the basic gross anatomy, and you'll see things like pericardial effusions. They'll give you flail MR or something like that. Usually they'll give you something fairly obvious in that view, or ask you to identify different structures. Remember, if you're in the esophagus, the left atrium is the structure closest to the probe, should be able to work it out from there. And then the mid-esophageal long axis, you can see mitral and aortic pathologies as well as aortic root pathologies. This is going to be the view where they ask you about a type A dissection. In addition to these three views, the view that resuscitative TEE recommends as another high-yield view is going to be that mid-esophageal bicaval view. And then the other ones that I would add that I think can be very useful in diagnosing aortic pathologies, pleural effusions, that's going to be that descending aorta and short axis, as well as the ascending aorta and short axis. And then the other one that I think is very useful for looking at problems with the RV, particularly, you need to know if this patient has a PE, and you can look for something called McConnell's sign, which you're probably familiar with the TTE, is looking at that mid-esophageal RV inflow-outflow view. With that, here are some citations. Again, take a look at this website. It's pretty cool. Has lots of information on it. And with that, I want to open it up to any questions.
Do you have any questions for Dr. Owen today? That was an amazing lecture about the use of TEE in the resuscitative setting.
Okay, I see a few things in the chat. Okay. Oh, excellent.
So I guess maybe I'll kick it off here. Maybe we'll see if anyone else has some questions. First off, I mean, I like the shout out to the resuscitative TEE project. That's where I went to get my training for TEE. I am not paid by them in the slightest, and this is certainly not a paid endorsement, but the folks over that resuscitative TEE project are really, really good about teaching and providing that education and kind of the background for doing TEE in my setting in the ED, but also in the critical care environment. They put on a really good course, so highly recommended if you guys get a chance to get out and do that. But I guess my question that I wanted to kind of throw at you here is, one of the things that we use TEE for in the emergency department is just guidance of CPR and like a cardiac arrest resuscitation, right? That's kind of where we started, kind of dipped our toe in the water and started expanding from there, or that kind of where we started kind of doing our initial TEE. So, one of the things I've appreciated is that it can be essentially a real-time monitor, like you mentioned, of the progress of my code. So I can just essentially put it down, stand back, and just kind of watch what's happening to my patient and not really have to kind of punctuate my CPR, my resuscitation with echo, right? So do you have any idea in terms of the safety profile? I guess at this point it's kind of a moot point, but the safety profile of continuous TEE, kind of vis-a-vis the thermal effects, not so much worry about the mechanical effects, but the thermal effects that may have on the esophagus, for these patients when used kind of over a prolonged period of time.
Okay, yeah. So certainly, I think one of the biggest things that you actually said on there is it is kind of a moot point, right? If you don't get ROSC, thermal injury is kind of a moot point. So I don't know of any kind of existing literature saying how long you can have the probe running before you're causing thermal injury. The probe will sometimes, depending on the software that you're using, we use Philips here, will give you a warning when the temperature is, I want to say it's cut off as above like 40 degrees. So it'll kind of give you a warning like, hey, you might be close to causing some thermal injury here, but I'm not aware of any specified time course in terms of causing thermal injury. But I would say the longer your code is ongoing, the less likely ROSC is, the more moot of a point it becomes.
And I think where it probably becomes a little bit more of an issue is when we think through expanding the indications of TEE in the resuscitative environment to someone who's peri-arrest or just critically unstable. Where if I've got them down in the ED where I'm going to be resuscitating for a couple hours, it may be nice to have that real-time monitor placed for a couple hours. And I think what you said is good. I mean, certainly we're not going to be nonstop at the bedside for 2 straight hours. So it gives us some opportunity just to freeze the image and maybe not contribute to that thermal injury or thermal effects. That's kind of where I'm thinking about it. And a quick search, none of this is verified in any way, shape, or form. So if you're watching this, don't hang your hat on this until we confirm it. And maybe I'll reach out to our burn folks, but just a quick AI search, because that's the way I do my searches lately, suggests that maybe 60 degrees Celsius is the temperature needed to cause a thermal injury in the esophagus, which translates to 140 degrees Fahrenheit. So intuitively that makes sense. I imagine it's, maybe you can burn yourself a little bit cooler than that. Again, I'd have to talk to our burn folks to kind of get a number. But it kind of makes sense if your probe's stopping you at 40 degrees, that gives you at least a 10, 15, 20 Celsius buffer before any serious injury can happen. So again, unconfirmed, just kind of thrown out there into the internet space and just kind of seeing what's a potential. So
one thing I would like to add to that, though, is that when you do higher level functions of the probe, so if you're using continuous Doppler, if you're using color Doppler, that actually generates more heat within the probe itself. So I certainly would not recommend keeping continuous color Doppler on for, hours at a time. But I've certainly echoed for pretty long stretches of time when we're separating from cardiopulmonary bypass. I'm actively imaging, half an hour stretches, pretty decently long times, and thankfully haven't had any esophageal thermal injuries that I'm aware of.
Great. Yeah. So just kind of for the people on the call, a little bit uncharted territory, but just experientially from Dr. Owen, it's okay to reset or to image for a period of time, but just try to keep in mind those TIs and MIs as we kind of scan our patients, just like we would if we were to do a first trimester or something to that effect. We want to, keep in mind the safety profiles for these patients. So any other questions, anything else that we want to chat about for TEE, specifically for Dr. Owen today?
That's Tom Neller. Dr. Owen, great talk. Thank you. One question about the C-spine potential limitations. How concerned should I be about potential C-spine injury in doing this, and how much manipulation does it tend to take?
So there are case reports certainly of spinal cord injuries in a patient who has known atlantoaxial disease. What I would say is that you would take pretty much the same precautions that you would when you're securing the airway. You want to minimize the amount of cervical extension and cervical flexion that you use. Often when someone's C-spine hasn't been cleared, you guys will still have them in the collar. And if you are still in a collar, or if you're holding manual inline stabilization, I think it's perfectly safe to place a probe. You can sometimes have a little bit of difficulty. Sometimes it might be helpful to have someone provide a bit of a jaw thrust just to get the tongue out of the posterior oropharynx to help you get the tube down easily. The other thing that I've sometimes used is using video laryngoscopy to help me actually place the probe into the esophagus.
Yeah, I've definitely done that last one when I have a hard time just kind of using my fingers to guide the thing down. Getting that tongue back out of the way with the laryngoscope can be helpful.
Yeah.
So what we're trying to do here in the department is basically for cardiac arrest, we generally have multiple residents that show up and then, at least one attending. And so we're trying to make the airway resident also be the TEE resident. So they put the probe or put the airway down, right? Secure that. We have a nice tube holder that has a nice open space where we can get the TEE around that. So if we don't have that proper one on, we get swap it out. Like if EMS comes in, they have a different one. So we'll swap that tube holder out, kind of get everything ready. And then, usually I or one of the other TEE faculties at the head of the bed will throw the thing down and then kind of work with the resident up at the top, doing that. So it kind of fits nicely into the workflow of that airway resident kind of now switching over to the ultrasound resident, and we have someone else at the foot then who's running the code. So it's a good team effort. So
absolutely. I think that's a probably really useful workflow.
Yeah. Any other questions, thoughts, comments?
Yes, I had a quick question. What level of expertise would it require to get to the level of being comfortable with, say, a fellow in the ICU placing the TE probe during these codes? Is this something that you can do 5 to 10 and be fairly comfortable with, or is it something that takes a substantial amount of practice to get good at getting it in the right place?
Absolutely. So to answer that question, I'll kind of rely on what the American Society of Echocardiography uses in terms of, for me, for instance, in being advanced perioperative TEE certified, I'm required to have performed over 150 echoes and reviewed 150. I certainly don't think you need that in order to be comfortable placing the probe. There are different certifications. So for instance, in a basic perioperative TEE certification, I believe those numbers are 50. You have to have performed 50 exams and reviewed 50 exams. I think unless you do a good enough number and run into the ones that are actually difficult to place, it can be a little bit you can certainly become uncomfortable if you haven't run into one that is difficult. But just completely anecdotally, without much evidence behind it, I would say placing, between 15 to 25 probes will usually give you opportunity to at least run into one or two that are difficult and give you the opportunity to troubleshoot those so that you're familiar going forward or comfortable going forward.
Yeah, and just a little kind of word on our departmental policy in the ED. I updated that not too long ago. And we say for anybody and I'm happy to share this policy, with you, John, if you need it. But for our faculty, right, who have already been privileged to do transthoracic echo, right? That's the prerequisite, which has its own privileging and credentialing requirements for our department. So if you've had that, we are going to follow the ASAP guidelines and recommend a minimum of 10 intubations with the TEE to then become independently privileged to do TEE in the ED. And then we have, some limitations in terms of what indications we can do TEE. It's cardiac arrest, peri-arrest, and people who are hemodynamically unstable, and all of them have to be intubated, right? We're not doing this without any airway securement. So we're a little bit kind of on the smaller side or shorter side of number of attempts following the ASAP guidelines. But again, that's predicated on, you kind of need to know the echo side, because we're kind of cutting some of that short where you don't have to necessarily learn how to interpret the echo, or we're making that independent of the TEE part, if that makes any sense. So I think every society is going to have slightly different guidelines, and Dr. Owens mentioned kind of what the anesthesia folks say, ED folks are going to say something different, crit care may say something different. So